Good morning, HCJ. It's good to be connected to you in this way. This is an exciting summit. We have an exciting panel this morning. We'll get straight to it. I will introduce the speakers briefly. You can read their more extended bios in the program, and I am introducing them in the order that they are speaking. Elizabeth Stewart is Associate Dean of American Health at Johns Hopkins Bloomberg School of Public Health, and she is on its COVID Mental Health Working Group. Sarah Vinson is a psychiatrist in child and adolescent and forensic psychiatry. She is an associate professor of psychiatry and pediatrics at Morehouse School of Medicine and an adjunct professor at Emory University. Her private practice is through the firm she founded, L'Oreal Forensics and L'Oreal Psychiatric Group. Dale Walker, also a psychiatrist, is director of the One Sky National Center for Indian Health and professor emeritus at Oregon Health and Science University. Thank you all for being here. We appreciate your time and your sharing of your expertise. Elizabeth, if you would jump in there, we're ready.
Wonderful. Thank you so much for inviting me to participate, and also thank you to the organizers for focusing on this topic. I'm so thankful to have this session focused on mental health during the pandemic. So yes, as was said in the introduction, I am a professor at Johns Hopkins at the Bloomberg School of Public Health, and since March have been working quite a bit on topics related to COVID and mental health. So I'm going to tell you a little bit about kind of just generally the state of mental health during the pandemic at a fairly high level. And I'm looking forward to the other sessions, the other speakers as well, because I think they're going to complement my overview really nicely. So see if there we go. So as you can see here, the pandemic, is getting a lot of attention in terms of mental health. There's been various news stories. Maybe some of you have written some of these that highlight some of the mental health issues. Sorry, I'm having trouble. There we go. That's better. You can see my slides better now. There's sort of lots of concerns about pandemic fatigue, lots of concerns about the intersection with racism, social isolation, all sorts of concerns that have come up. What there hasn't been, although increasingly there is much data to sort of inform what really is happening behind the scenes. And in ways that we don't, maybe can't even necessarily, again, sort of see directly. So what I'm going to talk about is some efforts that we have been involved in at Johns Hopkins to really try to get rigorous data on this question of sort of mental health at a population level during the pandemic. There's a lot of subgroups of particular interest. Some of our other work, for example, looks at families of children with autism. But what I'm going to focus on today is sort of thinking about how do we measure mental health at a population level so that we can understand what is happening broadly. I'm trained as a statistician, and so I want to start just by pointing out that one of the challenges here is that it is hard to study population level mental health. And there's sort of two main reasons. First is it's hard to measure mental health in general. It's, without sort of diagnostic criteria, we don't always have sort of great survey variables, for example. And then the other is that, again, it's hard to get population level data. We might have data on people already seeking treatment. We might have data on specific individuals in certain service systems, but we don't necessarily have population data that gives us sort of a broad sense. So in March, a group of us at Johns Hopkins started the COVID and Mental Health Measurement Group, which really had a goal of trying to get high-quality measures of mental health on some ongoing U.S. and international surveys so that we could monitor mental health during the pandemic. We used sort of these broad measures of mental distress, mostly focusing on anxiety and depression. Again, they are not diagnostic. They are sort of meant to be quick indicators of general mental distress. And again, we were trying to be efficient, so we teamed up with some other partners to put these on ongoing longitudinal surveys. And so trying to get, again, sort of build on some data collection efforts already underway. There are also some international surveys that we were involved in. Today, I'm going to focus more on the U.S. information. Let's see. There we go. Okay. So at a very high level, what does some of the evidence say? And happy to go into more specifics during the Q&A. But I'm citing a particular paper here, but really these findings are very consistent across a number of sources, that rates of serious psychological distress, and again, mostly you can think about sort of symptoms of anxiety and depression here, are much higher than before the pandemic. So about 4% of the U.S. population reported serious psychological distress in 2018, and that was up to about 14% early in the pandemic. What's, I think, particularly important is that we see high distress, particularly among certain subgroups, and I'm going to highlight three here. First are adults aged 18 to 29, sort of young adults. That was particularly interesting to us because I think especially early in the pandemic, there was a concern about older adults being isolated at home, and that mental distress might sort of hit them particularly. But in fact, we are seeing again, across sources that it's sort of the young adults that are feeling this particularly. And I think a theory for that might be that they're at a time in their life when they were about to sort of head out into the world and really sort of start their lives, and things are looking very different for them than they were expecting. A second group that is experiencing substantial increases are those sort of at financial risk. So those here, I'm listing those with household incomes less than $35,000, about 19%. Other, again, sort of, you can define it in slightly different ways, similar pattern. And again, this is not surprising. These are people who are experiencing perhaps real financial concerns as well as the health concerns of the pandemic. And then finally, there are some racial and ethnic differences. This particular study found increases, particularly among Hispanic adults. Some other work has seen some signals of particular increases among African Americans. And again, happy to come back to some of these in the discussion. Again, I'll highlight that adults over age 55 actually had the lowest rates of psychological distress, which was reassuring to us, again, sort of given some of our theories going into this. And again, a reason why getting the data is important to be able to inform things. What I'm showing here is from sort of early-ish in the pandemic. I don't have the details, but just verbally I'll say that the work in progress sort of shows some changes over time, but these broad patterns really still hold, and that we actually have not seen dramatic changes in mental distress across the country since March, which I think is important and also quite interesting. We've also done some work digging into particular groups that I think will have particular implications for policy recommendations. And in particular, we have investigated rates of distress among individuals with no prior mental health conditions. And this was of interest to us because these are people who are not already connected, or are likely not already connected to the mental health service system. We know that mental health in general is often undertreated. A lot of people have trouble connecting to services. And I think this raises concerns that during the pandemic, there's going to be even more people out there who sort of need to find ways to connect with the service system and maybe aren't going to have the resources or just know how to do so. And so we found over 25% of people in this group were experiencing substantial mental distress. I also just wanted to highlight some other high-level findings. These are primarily from the Centers for Disease Control and Prevention, showing 11% of people in the United States had seriously considered suicide in the past 30 days. And there's also evidence that substance use and alcohol use is up substantially during the pandemic. So I'll wrap things up just with sort of some high-level, perhaps moving towards implications and sort of recommendations. Again, sort of the data, and I've given you just a snapshot. Happy to talk through more details. But there's a lot of evidence that psychological distress has increased among adults during the COVID-19 pandemic. As the pandemic continues, there are certainly concerns about long-lasting and sustained mental distress. And I think we, as a field, have evidence. We know we have some previous disasters where we sort of have understanding of what happens. I think the length and the breadth of the pandemic and sort of how it's hitting people across the United States for such a long period of time means that we don't really have a good sense of sort of how things will evolve over time. There's also a lot that we don't know. So I just want to highlight, for example, it's very difficult to get sort of representative data on children's mental health. Most of the surveys that we have access to, again, sort of at a national level, are on adults. And I think there's going to be really important questions that we will have to monitor regarding kids, and especially with sort of uncertainties around school and them not being in their normal school environments. There's also sort of anecdotal concerns about intimate partner violence and some data indicating potential increases. But again, it's hard to get sort of national high-quality data on that. I think, again, the motivation for us in doing this work really is, to understand the epidemiology, but in a way that can help us orient resources for those individuals that most need them. I think a really important message is that effective prevention and treatment strategies do exist. We can provide people with some strategies to help improve their mental health, sort of in the immediate term, and then also know when to reach out for more professional help. I think as a whole society, there's a lot we could do to reduce stigma and, again, sort of reduce the stigma associated with reaching out for help and help people connect with either self-care strategies or mental health services. One really interesting, I think, perhaps silver lining of the pandemic is increased use of telehealth in general and telepsychiatry and telemental health. And, there's increases in that. There have been reduced restrictions on the regulations on that, and so it's been easier for people to access. And this will be important and interesting to monitor, especially in areas, for example, rural areas that have not had sort of sufficient access to mental health services already. And this might actually provide a way to link them to more care, even moving forward once the pandemic resolves. And again, I think the key thing is to just sort of reduce stigma, help people connect with resources, and help people learn sort of how to reach out and help each other. Just really briefly want to acknowledge the COVID and Mental Health Measurement Working Group. We have an amazing set of students and faculty and postdocs that are doing this, and some partnerships that have enabled us to get this high-quality, nationally representative data on mental health, which has been, I think, needed to really inform the questions and the discussions. And I realize this is going to be incredibly tiny font. I'm happy to email this to anyone who would like, or if there's a way to share it otherwise, but just wanted to provide some resources. On the Johns Hopkins website, we have a number of media stories and just sort of articles, and then the peer-reviewed publications for some of this work. So thank you so much. Hope this gives sort of a general introduction to kind of the state of mental health in the United States during the pandemic, and I'm really looking forward to the discussion. Thank you.
Thank you, Liz. Sarah, please.
Good morning. So I will just be speaking with outside, but we'll be coming at it from the perspective of a practicing mental health clinician, and I treat both children and adolescents and adults in both public and private settings. So I've sort of had a firsthand view of how mental health has been affected during COVID. One of the things that came up was that we don't have good data on children yet, but what we are seeing sort of at the ground floor is that children are having negative mental health impacts from this as well, which is not surprising. So all children are in the context of families, and those families are in the context of a community. So when a larger community or larger society is struggling, when their parents, their caregivers, these adults that are showing up in these surveys are struggling, then that has an impact on how children are doing and on their mental well-being. So I think it helps in thinking about a societal stressor and mental health to take a step back and think about that continuum. So sometimes in our discussions of mental health and mental illness, we can act as if they're two separate entities, and you're either mentally ill or you're not, or you're mentally healthy or you're not. And really, everyone is on a continuum between mental health and mental illness. And everyone at any given time can go up or down on that continuum. And there are things like protective factors, risk factors, prior history that can sort of place where you may sit at baseline. But then there are things like stressors, the ability to adaptively cope, maladaptive coping, that are going to move you up and down that continuum. And what we've seen with COVID is that stressors have gone up because of the illness, because of its impact on the economy, because of its impact on jobs, because of its impact on school. So at the same time that people need more coping skills, at the same time they need more tools in their box to sort of deal with life and deal with day to day, the disease has taken those skills and those options away. So things like vacations or going to concerts or going to college football games are all things that people aren't able to do to sort of blow off steam or add some balance to their life in the same way. So stressors have gone up and ways to cope with stressors have gone down or have been really limited. And in that context, what we see is that people find ways to cope, but those ways to cope might not be adaptive. It may be distracting yourself on screens. It may be drinking more alcohol. And over time, these things we know aren't good for your mental health either. So it's no surprise that we're seeing more symptoms, that we're seeing more illness, given that it's really a perfect storm for people to move further on that continuum toward illness. The other thing that's important to point out here is that much of what makes people sick or well, whether you're talking about physical health or mental health, has to do with the society, what we call the social determinants of health. Very little of it compared to those social things is attributable to things like genetics or getting the right medication or that sort of thing. And with COVID, all of our economies have been hit. We've also had a contentious election and now a very interesting transition process. And so there are things that are going on in broader society that are stressful, but that also impact things like housing security, food security, routines in school and work. And all of those things are really critical. So it's not just the illness itself. It's not just the fear of catching it. It's not just the fear of it impacting people in your family, but also these ripple effects it's had on things that are really necessary for people to feel safe and secure. And when we think about mental well-being, being safe and secure, feeling as if you're safe and secure is really the foundation for everything else. What I've seen in practice and what the studies that we do have bear out is that people with no prior mental health treatment history are now being pushed in that continuum in a way that they were not before. So you have some people who are presenting for care for the very first time. You also have people who may have had a history of mental health problems or who had more mild symptoms where those symptoms have been amplified or gone up. And before this, our mental health system was ill-equipped to meet the needs of our society. And with this happening, we have been in a position where we can't meet the needs again. So even though the expansion of telepsychiatry or telecounseling has been a positive, and it obviously was an underutilized resource before, it doesn't make up for the lack of providers, the lack of systems, the lack of slots in order to see people. And so the system itself isn't equipped to sort of handle this sort of new business, so to speak, that is coming its way. Another thing that I think it's important to point out is just the virtual school and what that has meant for children's mental health, and how it also breaks along class lines. So prior to COVID, there were significant disparities when it comes to education in terms of money spent per pupil, access to things like AP classes, and then you have the digital divide in terms of like having Wi-Fi at home and things like that. And we know all of those things impact educational outcomes. Even pre-COVID, if you look at a child, if they miss 7 days of school, that greatly decreases the chances that they're going to graduate on time from high school. Obviously, with COVID, there's been a lot more missed days. And what we've seen with that transition to virtual school is that the extant educational disparities are likely going to get worse. And this has to do with kids who have learning disabilities and with families who have financial insecurities or that don't have the human resources to help a child at home. So what I've seen as I can sort of juxtapose the experience of the children in my private practice versus my public sector clinic is that in the private practice, those kids who are in private schools have had much less of a disruption to their schooling because in many cases, those private schools have the resources, have the teachers, have the space to socially distance, to still provide a lot of support, to maybe even have the kids in person for the most part. My patients who are in the better funded public schools consistently have access to Wi-Fi, to a device. A lot of those kids also have tutors who can supplement learning, which is really hard to do in front of a screen all day if you're an adult, let alone a child. But my kids in the public sector clinic, for many of them, virtual school equates to no school because they don't have a device. They may be trying to do school on their grandmother's phone. They don't consistently have high-speed internet, and they don't have the resources to mobilize supplementary help like tutors or things like that help them sort of fill in the gaps. And so we're seeing that along class lines, but also if you have a child that requires special education, that's much harder to deliver in a virtual setting. And what is practically happening is that it's just not being done. And so you have kids who have these needs, and the way that virtual schooling is configured is not set up to meet those needs. And one of the things that we have seen is that with children not being in the school setting, they're not being arrested and sent to juvenile justice facilities, which is a good thing. And we've also seen juvenile judges be more deliberate about who they send to these facilities, knowing that these children can't see their family, that they're higher risk for COVID. And if you look at the juvenile justice population, their health as a whole is poorer than same age matched community-based peers. So something that we're concerned about thinking ahead to when children do go back to school is a resurgence of that school to prison pipeline or those children externalizing behaviors out of their frustration because they're so behind, leading to a disciplinary response rather than a supportive therapeutic response, which is going to be very critical for them. And it is entirely predictable that these children are going to have a very hard time transitioning back, given that they've functionally been out of school for at least a period of 3 or 4 months. Who knows how long it's actually going to be before they go back. So in thinking about mental health and COVID, yes, we need to make sure that telepsych services are available. Yes, we need to support the mental health providers, but we also need to do the basics, like thinking about food and where these kids are getting that lunch and that breakfast they used to get at school from now, housing stability, doing things that we can to shore up family support, because in the absence of that, we are very predictably going to have a significant decline in the mental health and well-being of our families, and that includes our children.
Thank you so much, Sarah. Appreciate it. Dale, you're on, please.
Well, hello, everyone. Indeed, I don't see the slides coming up yet, but as soon as they're there, first of all, I just want to thank everyone for the approach that we've had to discuss something called a hidden problem. The difficulty with mental health overall in our history is that we have trouble with the stigma of mental illness. We battle with it. And I think that's because it's a chronic illness. It takes time to deal with the problem. You can't just come in and treat it acutely. You have to manage it over time. Now, since my frame is fixed on the screen, I'm going to try to see if I can. Can you all hear me? There we go. I'm back on now. I can see a little bit. We're going to talk about the hidden problem, especially in relationship to native behavioral health. But I want to point out that this is a model that you can look at for rural health in this country, other special populations in this country, or the population in general. The interesting thing to me is that the way COVID has come into the country, it obviously started with the larger cities and the urban areas in that first phase. We dealt with it rather well in the early times, but we've gotten tired of it. We've had difficulty in maintaining a focus, and so now it's kind of scattered into rural, more isolated areas that are totally unprepared for it. And I would say that that's true for the American Indian population. I don't know whether the slide is switching or not. Okay. I'm sorry, my screen is freezing, so I'm kind of going this blindly. But the first slide I want to share with you is where American Indian and Alaska Native people live. And this is a county-by-county breakdown of Indian populations. Now, there are 2 or 3 things I want to share. If you look at that big blue area in Arizona and New Mexico, that's where a large population lives. The size of that is about the size of Switzerland. And Switzerland has 8.9 million people living there. There are about 400,000 people who live in this area, and their resources are not nearly as available as in more suburban areas. Hospital care, even access to food, access to water, access to electricity is a big problem in those blue areas as you look in this country. The other thing I'd point out is that indeed you have the issue that in a county-by-county breakdown, 70% of American Indian, Alaska Native populations live off reservation. And so what that means is that we have to work with states and counties and cities also, as well as the federal government, to get healthcare and education needs met. So anytime we have a crisis coming, we have multiple levels of discussion to try to find resources to address the problem. Now, there are 573 tribes that are federally recognized. There are about 100 that are state recognized, and there are another 100 that are not recognized by state or federal government. There are only 325 reservations, meaning that a lot of these tribes live off reservation and are trying to kind of work within their own community. The population in 2018 was 6.9 million people. Now, the one thing I wanted to do is to give a baseline of the pre-pandemic Native health morbidity. This is an important problem for us to think about because, we need to understand how these problems are evolving over time and what did it look like before COVID came here. We already had severe problems with chronic illnesses. Alcoholism and tuberculosis is 6 times the general population. Diabetes, accidents, poverty, depression are 3 times, suicide 2 times, and violence is increased, but we don't have the data to explain that. Now, the Surgeon General's review of this states that American Indian, Alaska Natives have the same disorders as the general population, but they have a greater prevalence, a greater severity, much less access to treatment. The cultural relevance is much more challenging, and the social context is disintegrated. So how does this all come together as we look at our pre-COVID circumstances? Why do American Indians and Alaska Natives have these disparities? Well, we talk about lower life expectancy and disproportionate disease burden that exists because of inadequate education, poverty, discrimination in the delivery of health services, and cultural differences. There are broad quality of life issues rooted in economic adversity and poor social conditions. Dean Seneca, an epidemiologist up in the Great Lakes regions of the Indian Health Service, talks about this, and it really fits into the context that you heard earlier of social determinants of health. And I'd like to share with you my view about these issues, that Indeed, we think about a crisis like COVID-19. That's a healthcare system problem. We need to have the equipment, we need to have the staff, we need to have all of the personnel. But there are other parts to the problem that need to go hand in hand with the healthcare system to address the problem. And, we look at the social and community context, the availability of food, education and maintaining our education ideals, neighborhood and physical environment, and finally, economic stability. I suppose I'd put another slide, a column on this, and that's political stability. Denial of the problem by the political leadership is absolutely ludicrous. The economic stability, we can't provide appropriate health care to get a good health outcome without having economic stability. Now, what that means is it's a critical discussion. Healthcare needs to work with the economic partners across the country, and we need to be hand in hand. We don't need to be talking about closure and arguing about whether closure is a good idea or not. We don't need to be talking about the use of masks. We need to have an understanding with our partners if we're going to provide the health care that's needed. So the situation that started in this time, what was that situation when the pandemic arrived in Indian country? Well, behavioral health services are under-resourced, severely limited access to health care. There's insufficient monies for chronic illness care, and there's poor housing circumstances, persistent poverty, staff vacancies in the healthcare system. It's all occurring against a backdrop of increased prevalence of mental health issues. So, that's so important for us to take a look at. And by the way, I want to point out again, this is a model that we can use across the system. It's focusing on Indian country here. We have a serious problem in trying to address access to care in Indian country. I think that we can learn from this and try to look at the population in general to provide a more effective approach. There are some data about what's going on in Indian country in regard to COVID-19. Three things I was able to find is the incidence of COVID among natives is 3.5 times higher than the non-Hispanic white population. That's from CDC. SAMHSA points out that COVID-19 has revealed deep-seated inequities in mental health care for communities of color and amplifies social and economic factors that contribute to poor health outcomes. Finally, NIDA points out that the substance use disorder patients have increased risk for COVID-19. A final point I'd make about this is that we do have major causes for concern. The Indian Health Service has only 157 hospital beds and 36 intensive care units across the country. Many people covered by the Indian Health Service are hours away from the nearest IHS facility, whether that's outpatient or inpatient. So those kinds of things are upon us as we begin to think, what happens if there's a huge problem on Navajo, on Pine Ridge, on Rosebud, on Cherokee, in Alaska. This is where the problem of COVID is now happening in this second phase. And so we need to be very prepared because the availability of healthcare in these areas are remarkably limited. Another point about, what's hidden about COVID-19 mental health. I wanted to approach this at two levels. The first is mental health, and the second is mental illness. There's a big difference between those two, and I wanted to point that out. Mental health, a definition for that is that it's a state of well-being in which every individual native realizes his or her own potential and can cope with normal stresses of life and can work productively and make a contribution to their community. But we all know that we all struggle with mental health issues from time to time. It could be problems at work, problems with your finances, problems with your relationship, and finally, life events that happen to you. That can be a death in the family, it can be the loss of a job, and it can be COVID-19. So we have these areas that affect us, and we need to talk about that and think that through. Then we need to talk about mental illness and the kinds of things we can do there.
Thank you so much, Dale. There's so much to unpack here. I want to start by reminding AHCJ members that the slides will be in the resources link, the PowerPoints that were here. But Dale, if I can start with you, and all of y'all can weigh in on this. In a moment like this, what is the sort of community's capacity to fill in, to triage where services don't exist? My Brooklyn church, for example, has a mental health ministry. It is staffed by certified clinicians. So I am wondering right now on tribal lands in the community, wherever, if there are things going on to fill in, this gap.
Well, I think that one of the unanticipated successes is the use of Zoom meetings and other kinds of action slide activities. I have one meeting that I meet with across the country that have over 200 participants from reservations around the country. We're working together to be able to develop a way of communicating and reaching out and trying to give information. That's part of the material of this talk, is what can we do to actually reach out and provide information for people. I think that that's a critical learning point. American Indian people will be able to solve a lot of these problems, but it's remarkable how few capable, trained people there are to provide direct care. And so recruiting, providing teams to get into those communities is an important part of the process.
Sarah?
We certainly have seen people have increased reliance on these informal supports or these non-traditional ways of getting mental health care. But something that I would raise there is that given the economic impact of COVID, a lot of nonprofits have seen their revenues go down as well. So the ability of them to provide services has been compromised because they're just not getting charitable giving at the same level now because people are more worried about their finances too.
Liz?
Yeah, I don't have much to add beyond what we've heard. I think I want to echo the comments about sort of distinguishing mental health and mental illness. And I think we can think about the strategies that communities can provide to sort of help people get past sort of short-term challenges or, sort of minor challenges, and then also know when to connect them to professionals who can help if they're having more severe challenges.
Sure. This question is for Sarah. You've been working with juveniles in detention. And you alluded to the school to prison pipeline, but I am wondering, in the criminal justice sphere, what is happening to folks you serve?
So what we're seeing happen in detention facilities, and I'm not providing direct patient care in a detention facility at this time, but what we've seen is that those children aren't able to see their parents and aren't able to see their families for visits because of concerns about COVID in the facility. So they have had severe restrictions on visitation, which, as you can imagine, would be difficult for an adult to deal with, let alone a child not being able to see your family while you're locked up. With this in mind, the system has made it a point not to detain as many children. And so we have seen numbers in detention go down relative to where they would typically be this time of year compared to last year. And something that's noteworthy with that is that we have not seen a significant increase in adolescent crime. So there were a lot of people in the juvenile justice community that were saying, we're locking up a lot of kids that we don't need to lock up for the sake of public safety. And now this is kind of demonstrated that we were incarcerating children who didn't need to be before.
Thank you. So these are questions that are coming into my phone. Thank you, y'all. And this one is to Dr. Walker. I am not familiar with the Alaska Native population. Would you tell us a bit more about this population and how it is recognized by the federal government or not, and if services are allocated in the same way as with the Native American, the Native Indian community population?
Well, that's a very good question because there is a difference. Many of the things in the lower 48 with American Indians has been settled in the 1800s by treaty and compromise and provision of health care and education. In Alaska, that did not happen until they went to statehood. And so the Native Corporations and Healthcare Act in Alaska is very different than a treaty. They do have remarkable televideo systems and ability to access, but I want to make an important point. You know, Alaska got through the first phase of this process in a reasonably good way, but now in the weather and the cold in Alaska, people are moving into their homes and communities, and the virus is coming with that. And so we need to worry about what's going to happen in Alaska with these isolated, smaller communities that are very vulnerable, very isolated to outside care. And, you know, as we know, the earlier we can go after COVID infection, the better. And we're very worried about what's going to happen in Alaska. And it is different because of the isolation. We have some of that down here in other tribes, but indeed, it's great concern to those that are involved.
Would you dig a little deeper into that? What are the similarities and differences in the mental health care constructs between Native American and Alaska Natives?
I think they're similar, if you will, but you know, a lot of it has to do with the time of contact with outside people, and how people have maintained their culture and their integrity, and so things are different. There's much more cultural involvement in the treatment process in much of Alaska, but I don't want to isolate that. That's present in Indian country down here in the lower 48 as well. But up there, it's really a very different kind of a context in working with the communities. Makes it a very special time to work with those people.
Here's another question. I'm wondering about multi-generational households. Different generations can have different stressors. Wait, okay, my screen jumped. I'm sorry. Different generations can have different stressors that affect others in the household. Are you seeing a cumulative effect of these stressors that hit those households or other special mental health concerns in these households? Liz, you want to jump in on that?
Yes, I do. Actually, I was thinking that. So it's a great question, and I think this is one of the nuances, and it was really good hearing Dr. Vinson's sort of comments about the clinical situations she is seeing. I think this is an area where we don't have a lot of information, but we have started to look at mental health among sort of the primary respondent to a survey based on household structure. And interestingly, we have not seen as much difference across that than we were expecting. We went into it sort of with all these theories about, oh, yes, people with children might be experiencing greater distress because of the challenges of dealing with them and the remote schooling and things like that. And actually the data sort of that we've seen borne out so far is that these other factors I've already mentioned, sort of just age, financial stresses, those are the key factors. We have not seen as much evidence that sort of the household structure itself in terms of the ages of children or whether it's someone living alone or with a partner. So that has been interesting. And in some ways, actually, some of the initial evidence, at least, is that households with children in them actually are experiencing less distress than some other households, at least, again, sort of early stages of the pandemic. I as a parent of two kids, one of whom's over here, I think we need to continue monitoring that especially as the fall has moved on and children didn't go back to school, for example, as we might have all have hoped for the fall. So again, I think important to continuing monitoring, but so far from what we've seen, there hasn't been as much difference due to that than we were expecting.
What do you see in households with single people? What do the data show there?
So far, we're seeing very similar rates to other groups. Again, I think these other factors, sort of age in general, and then also the financial stress, I think, sort of one of the financial stress factors that we have seen, that just to dig into that a little more, is, for example, whether someone has lost their job. Again, not surprisingly, as we heard about from Dr. Vinson, of course, that leads to just overall stress. But the fact of someone being single has not shown up as a strong predictor for us. And I think a lot of that, I'm hopeful that a lot of that is that people have been creative about finding ways to connect virtually or through walks outdoors in small groups, things like that. And so I think people have been, again, creative and resilient in finding those ways to connect, even if they live alone.
And so we're on a continuum here. There's another question for you, Liz, and it's this. Within the younger adult category with distress, does economic stress play into this? And if it does, to what extent? And the questioner says, I am thinking of young people who might be impacted by restaurant bar closings or limited in capacity and other business types that are especially affected.
That is a great question. Offhand, I can't tell. We have not examined that directly in the data, but you're giving me a great idea for follow-up research to look into that subgroup. I think you're exactly sort of the question is, we've been sort of looking at these individual factors, but what really might be important is the crossing of them, that sort of being young and working in a low-wage setting or an occupation that has experienced more job losses might be sort of doubly challenging for these young individuals. And it's sort of related. I think many of them will be graduating from high school or college and looking for jobs at a time when it's just hard to find a job. So not even losing a job, but sort of actually going out into the job market for the first time. I think those are certainly things that are adding to the stress for that generation.
So I'm curious about this, particularly for people who may have had been in some mental health care pipeline. As COVID continues, given the whole notion of resilience, are people adapting? To what extent are we developing coping skills? How is resilience playing into this long haul work of trying to be mentally well? Sarah.
Yeah, so, resilience looks at when you have risks or when you have something difficult and you're able to withstand it. But often there are protective factors that are going to increase your risk of being resilient. And so, yes, people do sort of re-equilibrate and they find new ways to cope. But that assumes that there are those options available to them to utilize, that they have resources available to sort of mobilize in order to do that, right? So I, as a psychiatrist who owns my home, can say, I'm going to get this workout app and do these things every day, right? But everyone is not in that position. If you are in New York in a one-bedroom apartment with no window, let alone a balcony, let alone a workout room, right? And so what I have seen and what I think we'll continue to see is that you do see some ways where people might sort of adjust based on their expectations. And, as one of the other speakers mentioned, we thought people would go back to school. Now they're not. So this is the new reality. So adjusting to these new realities keeps requiring things of people. And at some point, some folks are not going to have it to give, and they're going to sort of tap out their adaptive coping mechanisms. And what we're also starting to see is some of those maladaptive coping mechanisms, like starting to drink a little bit more, starting to smoke a little bit more. This is going on for a period of months, and now we're starting to see where this may be starting to catch up with people. So yes, we hope for resilience and we think of ways to foster it, but it's not that this just going on a long time is automatically going to make people more resilient. It actually takes practicing more adaptive skills and having the resources and the support to practice those things.
Okay. I'm going to pose this question, and Dale, maybe you will jump in it, and then it's a kind of a question for everybody, but I want to start with Dale. Native American communities have seen toxic stress for years, historical trauma, discrimination, violence, and now the pandemic. Will this mean that the pandemic effects will linger longer than it will in many other populations? And this would also, on some level, be true for other populations of color and certainly for the poor. If so, are efforts existing to get ready for post-pandemic needs? Dale, you want to start with that one?
Yeah, that's nice. It ties in a little bit with the last question, and maybe I can start with that. I want to make a distinction between what you do to help someone's mental health and what you do to provide mental illness care. The big issue about mental illness care is that it's interrupted in the way that it's being done across the country. In Indian country, that means that you don't get to see people as often, and maybe you don't get the chance to have an interview about your serious mental health problem. And so those people that have more difficult problems are being seen less in different ways, and we even have to kind of figure out how do we provide medications to keep them from coming back and forth, but have safe medications so that they can monitor their care.
Would you, before you go on, what do you mean by safe medication so they can monitor their care?
Well, if you have a person who is suicidal, you want to be very cautious in the amount of medications that you give, but you don't want them coming back and forth. So you have to mail it once a week, as opposed to having them come in once a week for getting the medication. So you want a safe pathway. You don't want to give them medications that might be hurtful in large amounts, for instance. Now, I'm talking about serious suicidal issues or other psychotic disorders and such. You want to be careful how you manage that in this more intensive time period. Now, mental health is, the difference is mental health, we're all challenged by this, and that's where you get at your historical trauma and all of these difficulties and how we get through the problems. I think that we need to just talk about, develop strategies that are positive focused and try to reduce the stigma of, making it okay to talk about these stresses and difficulties. We're not rounding the curve on problems. We're having problems, and it's okay to kind of talk about that and talk about the changes over time. That's the way to really address a chronic anxiety or depression, so that we can kind of keep it in hand, be aware of the problems, and make it okay to talk about. Your question about do we need an extended strategy? I think we do. When we talk about in World War II, when people came back, we needed to figure out a way to provide care for the people who were having problems with the war. And that's how we came up in the National Training Laboratories with group therapy approaches to treatment. It might mean that we need to think about this in that type of a way so that people can begin to think about how do we manage large clusters of anxiety, anger, the anger about masks and these people who are saying for Thanksgiving, nobody can tell me to not take my families in, I'm going to do it my way. The argument has to do with survival. And we need to be really careful how we kind of talk about these things and incorporate some way of helping one another hand in hand. I think that's the way that we need to approach this, Katie, and I think that if we can do that early on, we set the keynote for recovery in a nice long-term chronic illness care model.
Sarah?
Yes, I absolutely agree with all of that, and thinking about those social determinants and upstream, just realizing that there is really mental health in all policies. So yes, it's important to shore up the mental health care system or the mental illness care system, but also realizing that when we look at mental health outcomes, there's a significant correlation in terms of the safety net and how people do mentally. that's there, even apart from what the mental health care system looks like. And so when we have conversations about mental health, we also have to have conversations about housing instability and food security and those other factors that we know are really important in terms of how people do mentally.
Liz?
Yeah, I'll just, again, this set of two questions I think is nice, and I'll just add in one insight from the data that we have that does look longitudinally, where as we've sort of, I think, been alluded to, especially by Sarah, we've seen some increases in mental distress that happened sort of fairly early in the pandemic. It has sort of evened out to some extent over time. Sort of there was an increase, and then, we're not back down to kind of base rates, but there has been sort of a decrease. But there are certain groups where that has not happened as much. So women, for example, is one group where mental health for men has basically sort of gone back down more so, but women are still experiencing greater levels, at least in the data we have, and that might be sort of related to some of the, especially the schooling sorts of conversations that we've already heard today. But I think all of this is, this is going to be a long-term thing, and there are these structural factors that we've heard discussed about housing and food insecurity and service systems in general. The pandemic is, I think, focusing attention on them, but they are long-standing challenges that we are going to have to really work to help move the challenges away longer term.
So sort of added to that, there's this question about given these sort of economic, social deficits and deprivations, for folks who have been in care, who are in marginalized community, as the journalist writes, what are the prospects of relapse if they've been in care? So what's going on right now on that level? Sarah, Will, perhaps?
Sure. So it increases, right? So when you have systems that are in flux, and the other thing that we haven't touched on yet is the hit to state budgets and what that has meant to public mental health care spending. And certainly in Georgia, we saw significant cuts to our mental health care providers that are supported by the state. And if you're thinking about things like severe mental illness, substance use, the state decisions are really significant in terms of what care looks like and what care is available or not. And so there's a piece of this that has to do with just trying to protect the current services you have from further being cut because of state budget shortfalls.
Jill, do you want to weigh in on that question?
I think that's a very, very good point that's being made about how we find the resources to manage this situation. And again, when we talk about the hidden issues, when you begin to focus on the pandemic, you need to also include and direct resources into mental health. And the point made is that it's being taken away. And it's just at the wrong time, and it's wrong-headed. We really need to address these problems. Now, another point I wanted to make is that, mental health issues, serious mortality issues are happening in this country. We have increased suicides. We have, increased broken homes, increased death in relationship to this problem. And those are going to happen, and we need to and increased substance use disorder. All of these things are happening now, and we're being hit with this right when the time when resources and budgets are being redirected or taken away. We really have to have the resources from the federal government to help the states and to help those populations that are in need.
This question is for Dr. Vinson. Will you elaborate a bit on how the erosion of the foundation of safety and security negatively impacts kids' mental health?
Sure. So that is really the foundation for mental well-being. And I'll give you an example. I did an evaluation last week, actually a forensic evaluation, but it was someone who's an adult now, but who never had that security and that safety when he was a child. And when I asked him what his strengths were, the only thing he could come up with is surviving. That was the only strength he could name about himself, because in his life, that took all of his headspace to do. That was what all of his energy, all of his effort had to be trained on. So when you go back to that definition of mental health that was shared earlier about being able to work productively and fruitfully and contribute to your society and realize your potential, you can't do those things if you're worried about whether you're going to have enough food, shelter, basic necessities to see the next day, the next week, the next year, right? And so much of what we ask of children, particularly when it comes to schoolwork or following the rules or being engaged, requires them to believe that they're going to grow up to be an adult and that they have a future, which you may not have if you don't have that basic sense of safety and security. And it also requires them to believe that they actually have some control over how that future is going to look. It requires them to believe that their choices, their decisions, their actions can shape that future. And our word for that is having a sense of an internal locus of control. And when you have trauma, when you don't feel safe, when you don't feel secure, you don't have those things. And so, thinking about sort of realizing your potential or self-actualization or being happy is a luxury that you may not have if you're just thinking about, am I going to make it till tomorrow?
Without violating HIPAA, that kid you doing the evaluation on, would you paint a little bit more of his profile of his life?
So he was raised in a family with 6 children. He was the oldest son. The mother had a very severe, untreated substance use disorder. And so he ended up failing, and he also had intellectual disability. So he failed school multiple times. He was 12 years old in the 2nd grade, dropped out at that point, and became someone who was in the streets trying to make money, to get food, and to get clothes for his siblings. And there were different times when state agencies were involved, but never in a way that stabilized the family, never in a way that provided his mother with the treatment that she needed. And it put him on a track to ending up incarcerated in his early 20s, and he's been incarcerated since then. So almost all of his adult life, he's been behind bars.
Okay. This question, I think, is to Liz, but there may be parts of it that Dale, you and Sarah might want to weigh in on. Liz, you've talked about the lack of data on kids' mental health during the pandemic. If there is data worth looking at all, where is it? Is there an expectation of what this might mean with respect to ACEs and long-term mental health effects, and what specific groups of kids, teens, special needs kids, hungry kids, homeless kids are you worried about?
I think the person who put the question, I think in some ways has the answer in the question. There's, and I should say there is some data available on children's mental health. A group out of University of Wisconsin and actually Vanderbilt has done some studies, I think overall showing the same themes that we've talked about and what the question sort of alluded to, that the highest risk for the challenges right now are those kids who are in unstable environments without food insecurity, without stable housing. Those are certainly the kids that we are worried about. This is also, I think, why some school districts are trying to at least provide some of those supports. And I think we need more creativity from school districts to figure out how, maybe if they don't feel they can bring all of their students back, how can they provide the supports to the kids who do who are at higher risk, and maybe there are ways to at least provide some of those supports for them, knowing that schools provide much more than just an education for kids, an academic experience, but for many, the school is their source for meals and connection to health services and social services. So I think there's a general feeling that those are the kids we need to be watching out for, and hopefully there's sort of efforts by local communities to be doing that.
How do you do that during COVID? And if you know of particular school districts that are doing that work, what are some of the details of what they are doing exactly?
I think a lot of it, I think Sarah wants to weigh in, but I'll just quickly I know I live in Washington, D.C., and D.C. Public Schools, for example, is moving to set up what they're calling CARES classrooms, so providing a safe place with internet access, where it's, a classroom where the kids will still be doing their remote learning, but in the school building supervised with some staff members, I think food provided. And there are some other community organizations that are doing similar things, sort of, again, like physical distancing in the building, but giving the kids a location to go where they can do their learning, have some supervision, even if it's not sort of a formal, kind of a normal classroom experience. But I think it's that sort of thing. Also, even just trying to bring special education students back more quickly than, say, the others, or sort of being strategic about bringing back the kids who are, maybe the younger kids where pre-K experience is more important in person than a high school experience, or those youth who are experiencing real challenges. So it's that sort of creativity of kind of, if we're going to bring some kids back, how do we figure out the ones that are going to get the most benefit from being in person with some caring adults?
Sarah?
Yes, and there are ways with virtual schooling to know who has logged on and who has not. Right, so it's not like we're operating in a black hole here. We can see which families are having a really hard time engaging with this platform, and perhaps provide more resources or bring those families back more quickly. The other thing is, at a population level, we know which schools are underfunded. We know which schools have kids 99% on free lunch. We know which communities aren't as connected in terms of high-speed Wi-Fi, right? So there are things that we don't necessarily need data or studies to tell us. We already are aware of which communities are resource poor and which ones are going to need more assistance. And so just proactively providing that rather than sort of waiting and saying, oh, we don't know which kids need help. Yeah, we do. We know which communities need help. It's quite clear because our schools are very segregated still along racial and class lines.
Gail, do you want to weigh in on that?
Well, the school systems are an interesting problem. Great variability across the country in all of these Indian communities. There's on-reservation boarding schools that are struggling with this. So, looking across, I think that the ideas you've heard are exciting. We have a lot to learn about how to do kind of acute care and electronic learning. I've seen that personally out here in Oregon, and I think that it's an exciting way. We're trying to figure out how to socialize the process so kids can share and work together and even play together on the computer so that it's a part of the school system as well. That part of the child-to-child communication needs to be picked up on. And again, I think that if we look at this as an opportunity as opposed to a problem, I think we might learn something out of it.
You said there's some exciting things happening in Oregon on this front. Could you give some examples of that?
Well, I think that's the major point, is that people are learning how to improve communication between children during the learning process. That's the biggie that I would want to point out. Other things are happening. I can tell you that we're using the model in school, not just to work with the children, but to make sure that the parents are comfortable, that everything's going on okay with that family. So we try to target that. If there's needs there, we can try to address them as well.
I'm particularly interested in what is going on right now with folks with severe mental illness, schizophrenia, etc. What's happening in that world? And that question certainly is for Dale and Sarah, but also you, Liz. What's happening right now? Sarah?
So that population is one of those vulnerable populations. So, when we talk about children, we talk about the safety net. That applies to people with severe persistent mental illness as well. They're more likely to rely on public transportation or the community mental health providers or things like that. And so those same cuts that impact social determinants of health are going to affect their mental well-being. They're more reliant on things like Medicaid and community mental health centers. So when state budgets are cut and state mental health budgets are cut, that is going to have more of an impact on them. we have seen that the criminal justice system is trying to be more thoughtful, just as it is on the juvenile side, on the adult side, about who they actually place in facilities, because they realize that this is a vulnerable population medically. So there are efforts not to have them shunted into jails or into the criminal justice system, but certainly this is a population that is going to be more sensitive to shortfalls that impact the safety net and mental health care.
I was on a webinar yesterday that was actually on prisons and jails and correctional health care, and one of the panelists said part of what is going on in their mind is that some people are not being incarcerated because, and given the disproportionality of mentally ill people who are incarcerated, because they don't want folks dying in their jails amid COVID.
Absolutely.
Okay. So it's not all beneficent kind of stuff. It's some other.
Well, I mean, that's good. They don't want them dying in jail. And again, like, I think it is, hopefully, I do sort of criminal justice system reform work too, and we are hoping that people will take this as an opportunity to rethink business as usual when it comes to how quick we are to put people behind bars. And this is showing, one of the many problems with our current approach to incarceration in this country, and our problem with the criminalization of people with mental illness. And yes, people don't want, those deaths on their watch, but I will say it's very hard to get the criminal justice system to change what it does. So even if they're not doing it for all the right reasons, I'm glad they're doing something that gives people, better outcomes potentially.
Jill, would you tackle that question of severe mental illness? And also, before COVID, what did that look like on tribal lands?
Well, I think you really, when you talk about hidden issues, this is one that we really don't want to let go of. By and large, mental health workers spend about 80% of their time working with mental illness problems, severe problems that need difficulty and need attention over time. And so monitoring both medications and different types of therapies with that population is a large part of what we do. Well, during a session of COVID and over time, that is pulling us out of that and having to pay attention to the burnout of healthcare staff, taking care of problems across the community. And so there's a real stress about providing adequate care. Now, the other problem that happens is that what do we do with people we see routinely in our therapy environment when they can't come in, and when they can't get medications, or when we can't see them as often, or our healthcare facility is unsafe environmentally to bring people into it? And so, it's a lot more complex than we think of. Being able to kind of deal with this huge increase in need while we have patients that require need already. What I have seen is we go through a negotiation process with each individual patient who is struggling with a mental illness about what their needs are, so we can maintain them and try to do telephone or televideo support. I think that saves a lot of time. We're training people to work with these individuals as other workers can, and we try to help the family of that person so they understand the potential risk and the problems and how to protect. It's a very, very difficult problem. I can say that is very true for Indian communities, but it's true across the country. We really have a problem trying to make sure we maintain the good health of the mentally ill patient.
I have a fast question, I think, for Liz before we sort of do the big think questions as we wind down. Is there racial and regional data on first-time users of mental health services or people who are seeking that for the first time?
Great question. I assume the question is framed within the pandemic. And yes, there is that data available. We have not looked at it yet, but I'll reference, so the U.S. Census Bureau has been running a household pulse survey. And I just learned this week that they actually have some questions on mental health services, which is exciting and I think really wonderful that they have focused on that. And so there is that data available, and that would be available. The sample size is big enough to look at states. We have not looked at that yet, but I put it on our radar screen once I learned about it. The short answer is I think in the future we'll be able to learn more about that, of sort of who is accessing services. And I actually will just take the floor for a second to expand on the previous question, because I want to just echo sort of some of the sentiment that you heard kind of behind the scenes, which is that we've been doing having some conversations with harm reduction agencies for people with substance use disorder. And I just want to highlight the efforts that they are going to really keep their patients connected to the care that they need. And we've just been hearing really impressive stories of the work that they are taking on to make sure that people are still getting the medications that they need, that they're getting their services in these innovative ways. And so I think back to Dr. Vinson's comment earlier about these nonprofits who are doing huge, who are maybe experiencing some budget challenges, but are also really stepping up and really helping ensure that the patients that they care for are getting the services they need. And we've seen that in the substance use area in particular.
Before I go on, I want to go back to something that you mentioned because it was on my list. What is happening to mental health clinicians, practitioners right now? What's their state of wellness or not?
I can just briefly say that's a great question and really important. And we've seen healthcare providers in general experiencing substantial burnout as they are being called on to do so much. We have a team at Johns Hopkins who do some work with healthcare providers in general, and then my colleague Johannes Thruel has a project looking at mental health care providers in particular and looking at mental health. So short answer is I don't have data for you right now, but certainly if people are interested, I would be happy to connect you with people who are really getting some data on that and learning about it.
I know how to spell Johannes, but how do you spell his last name? Or
Thrul.
Okay. So in this COVID environment, or rather, how is COVID changing the policy landscape? What do y'all hear about what a Biden administration might do? What would be your suggestions? Sarah, I want to start with you.
So in terms of how it's changed things, restrictions on providing mental health services have been lifted. It's unclear if they will be lifted permanently. I know there have been some recommendations that they are. So that would be something that we would definitely welcome in the mental health care provider community, realizing that some people we need to see in person more, but just having that flexibility has been really important and something that I hope we continue to have. From a policy standpoint, something that I think would be incredibly beneficial is if the reimbursement rates for Medicaid were increased. So part of what we have with Medicaid is that there are a number of providers, there are a number of systems that have a hard time providing Medicaid services because it's not reimbursed at a rate that actually covers the cost of providing the service. Or if it does cover it, it barely covers it. And so it's just not financially sustainable for people, even if they want to provide services to people who are insured by Medicaid. When you look at Medicaid reimbursement compared to Medicare or private insurances, it's a substantially lower reimbursement rate, even though the work for a patient population that has more of these negative impacts on social determinants of health is often increased. So as a simple recommendation, that would be one that practically would allow for more people to provide services and to provide them in a sustainable way.
JL?
Well, it's an interesting and a tough question. I would maybe want to go to the CARES Act, some of the recent monies that have been distributed across the country. A large amount of money was sent out to Indian tribes and reservations. And the interesting thing, they have lots of stipulations about how the money is spent. Most of the tribes do not have the administrative support and management to actually set up the policies and procedures to spend that money down. It's remarkable. And they also, by the way, I think you all know there's a deadline on spending, which is December 31st. The interesting thing is there's going to be a large amount of money turned back to the federal government because people don't know how to spend it. We've set up a group of people to help develop policy and strategies for, taking care of the environment, providing extra resources for schools and homes and such. But that's not available, and there was no structure developed to have it happen. My hope in the Biden administration is that indeed we can kind of work this through in a way that direct support happens, and it's a logical process with help to assist in the process of spending down the money in an appropriate way. That's a very, very chaotic and frustrating situation. There are some tribes sitting out there with $100 million that it's not going to go back, and it will go back.
And this was money not just for health and mental health care, but a whole array of things?
That's right. The CARES Act was for all of the COVID issues. And so you can talk about housing, water, healthcare supplies, all of those things. It's a huge umbrella. But how to spend that money down is not something that the tribes have the experience with in getting the mission accomplished in a short-term time. We need to have some thought to go into that.
So you're saying they didn't just lack the technical capacity on health issues, but on all those spending issues. So on all these areas, money's going back.
That's right. That's right.
Okay. Liz, you want to tackle the policy question and COVID?
Yeah, I don't have much to add beyond what you've already heard, which I think are really important points. One thing that I have found that I was happy to see is that Biden's COVID task force does have some people on it who have real attention to the social determinants of health and some of these sort of underlying structural problems that we have. And so I'm hopeful that task force will sort of help think through how to sort of solve these underlying problems as a way to sort of solve the COVID challenges. I think mental health I have not yet seen a real focus of that group on mental health, and it might be that they are really they're first tackling testing and vaccine and such. But I really hope that task force will turn to these underlying mental health challenges and sort of have that also be a focus.
And so I have a couple of last questions, and this is the wrap up. We want to sort of get y'all's ideas of stories that need to be done, whether there's some existing news coverage out there that you think isn't quite right, needs to be corrected. So what are the pandemic-related stories about mental health? Also, in your discussions with colleagues, is there any current or planned research that we should be looking out for in the months ahead? Liz?
Yeah, that's such a good question. I would highlight, I think that sort of there hasn't been much yet on the services and treatment and prevention. I think one message that we really need to get out is that there are effective treatments for mental health, for mental illness, and for people who are experiencing distress. And so I think stories that sort of highlight people who are successfully sort of receiving treatment, who have found their way to prevention strategies or treatment strategies, I think would be really important. I think sometimes in society we view mental health problems as intractable and just a thing that happens. And I think I would hope for some messages around kind of that there are strategies that we can put in place from both a public health perspective and a medical perspective. In terms of future work, I will give a plug for one piece. I haven't talked much about it, but we have access to a large-scale survey that's conducted on the Facebook platform that is going to allow us to look at mental health down to the community level, so maybe counties. And so we're just starting to look at sort of these communities and sort of that might be, we have theories from the conversation today even about who might be sort of experiencing particular challenges, what communities, but I think it will help us really sort of be able to target who are what are the locations and characteristics of those locations that are experiencing challenges. And relatedly, some work also on sort of school reopening and how that sort of will impact things. So stay tuned for those.
I would just encourage anyone writing about mental health to always do that in the context of family, community, the larger society, recognizing that there is mental health in all policies and not just the ones around sort of Medicaid and treatment and billing codes, but things like access to good water and food and all of those things. That it's a really important and overlooked aspect of mental health care, not just for children, but for all of us. And in terms of upcoming work, so this is not a COVID-specific work, but it does have a lot of these issues discussed. So I'm the co-editor of a book, Social Injustice and Mental Health, that's published by APA Publishing. It'll be out in January. But it really talks about these societal traumas, these political determinants of health from a social justice standpoint, and the interplay between things like the healthcare system, the DFACS or the child protective system, the education system, and what that means for people's mental well-being.
Thank you. Dale?
Well, a couple of points. When one looks at the burden of illness upon people of the world, depression, anxiety, suicide, and alcoholism are in the top 10. And, you know, we overlook that easily in this country and try to look at the acute care problems and treat them quickly. And those long-term problems are seen in a different way, as Liz was suggesting. We really need to raise the visibility, and I think social determinants of health is a way to do that. So we need to talk about mental illness. We need to talk about mental health and how that works. Now, the second thing is a very important issue with American Indian populations. When we try to do statistical analysis of health needs, American Indian people and Alaska Natives are left out of the formulas. We're usually called other. But recently, one of the news organizations had a data chart that said white, Hispanic, Black, and something else. I can't tell you how much criticism that has raised in Indian country. We don't like to be called something else. We don't like to be fit in that category. It becomes a real issue, and I think the sensitivity of who we are. And by the way, you know, Black is a very interesting. There's all kinds of categories within that, and Hispanic, and people are beginning to talk about those differences. But you know, that's an important part of how we look at this country. You know, race is raising its head for many reasons right now, and we need to kind of think about what that is all about. You know, I would suggest that we have to find ways in our epidemiology to look at incidence and prevalence for all populations. Those of us who work with Native people are always frustrated because you know, there's arguments. We got to deal with methamphetamine. We don't know the prevalence and incidence of methamphetamine in Indian country, but we throw money at it. And, you know, there needs to be much more resources put into how we deal with these special populations issues.
That was a perfect ending. This has been a wonderful, rich panel. Thank you all for being here. We are out of time and on schedule. I know that two of you are going to the breakout room, and Sarah, I think you have to go to work, right? Thank you so much, y'all. I appreciate it. We appreciate it so much. All right?
Thank you.
Here now. All right.
Goodbye.
Bye-bye.